We are live on Facebook now. Namaskar. We are here today in the fourth edition of our COVID health plan. And we are very pleased to welcome Dr. Vikas Jogi. Dr. Vikas
Namaskar.
Jogi, namaskar and welcome.
Namaskar.
And Nija Sadhuji, welcome to you as well. So, Vikasji, we have had you in this webinar before. Everybody knows you very well. You are a reputed infectious disease consultant based in Texas, and we are looking at you to give us advice on what the latest evidence is on COVID. So the situation in India continues to be worrisome, and there is lot of information, but it is quite haphazard, the information, and especially for lay people who are not medically trained, it can get very overwhelming, as we have seen with our own relatives and friends, because there's an information overload coming from all kinds of corners. So these webinars are our humble attempt to streamline the information that we are going to share with the wider community. And we invite the audience to post questions on Facebook. And we'll be very grateful if you can answer the questions, time permitting, depending on how many we get. So let's start with today's session. Like I said, we've had 3 sessions already. That the first 2 were focused on COVID, and the third one was really around psychological issues that we have seen with COVID. So today we are going to go back to the medical treatment of COVID. And one of the things that we haven't discussed in great length till now, although we did touch on it with Dr. Rana the day before yesterday, is what is the evidence base for all the treatments that we are using in COVID. So you see what is happening, which is my personal experience with friends and family back home, is as soon as your COVID test comes positive, there is panic, which is understandable because this is a very uncertain situation. So and the next thing which everyone is doing is frantically looking for 4 different categories of medication. One is the antiviral remdesivir. One is the steroids, dexamethasone, methylprednisolone, then plasma exchange, and then the monoclonal antibody. I find it difficult to pronounce. Tocilizumab. And then there is obviously attached to it, there is shortage and there is a lot of anxiety around it. And unfortunately, there is a lot of black marketing going on, which is really unfortunate in present situation. So Dr. Jogi, today we are going to talk about what is the evidence for each of these. So before we start, could you take us through the various stages of COVID, starting from mild to severe, and then we can talk about what treatment is best suited for each stage of the illness. And thank you, Dr. Jogi. And
thank you, Shafalikaji, for introducing me. COVID is divided into asymptomatic and symptomatic COVID. 80% of cases of COVID are asymptomatic, and they will probably be okay. And these include both detected and undetected cases. Now, 20% are symptomatic, and these range from mild to critical. So mild illness happens when you test positive for COVID and you have some non-specific symptoms. These could be cough, fevers, body aches, not shortness of breath, sometimes abdominal pain, diarrhea. So multiple systems can be involved. But at this stage, there is no pneumonia in the lungs. Then moderate cases are those people who develop a pneumonia in the lungs seen on chest X-ray. They may have the sensation of being short of breath, but their oxygen levels measured by pulse oximetry are still over 90% on room air. So if you have a pneumonia, but you're not in need of oxygen, you have moderate COVID. So then severe and critical patients are those who are admitted to the hospital. So severe cases are those who need oxygen, and that can range from basically from 2 liters to up to 5 or 6 liters, which you can give by a regular nasal cannula. Then critical would be if they need the high flow nasal cannula, or they need to be intubated on the ventilator, and of course the BiPAP machine in between. So severe to critical, they kind of merge into each other. depending on oxygen requirements. So these are the various stages
Yes.
of COVID.
Yes, thank you. So oxygen seems to be the most critical thing because it is primarily a lung disease. So oxygen, obviously, we don't need any evidence. We all know that that is going to be the mainstay of treatment once the infiltrates in the lungs have started. But but if you take us through the other drugs that we are using or that are being used for the treatment of COVID, and your own experience of using them in US, and also we will touch a bit upon the what is the evidence, because now 1 year later we are getting some evidence in the trials that are being held across the world. So we are getting evidence for these treatments. So if we start with steroid, because steroids are being used. Steroids are very easily available. They are very cheap to get in normal situations. I don't know how it is now, but dexamethasone and methylprednisolone are very common steroids that are used in multiple illnesses, primarily asthma and all. So sometimes people have these at home as well. So what is the evidence for a steroid therapy, and at what stage of the illness is it really effective?
Uh, there's very strong evidence for the efficacy of steroids in patients with COVID pneumonia who are on oxygen. So they have to be severely ill to be on steroids. And steroids have documented improvement in mortality, so they actually are life-saving drugs. The steroid, which was primarily studied for COVID, was dexamethasone, Decadron. It's widely available in India, and it comes in both in oral and intravenous forms. The oral form can be used if you can take by mouth. If you're critically ill and you cannot take by mouth, then intravenous can be used. And the dosing is, you usually use 6 milligrams a day, and you can give it up to 10 days. Beyond 10 days, there's a gray area. We generally switch to another steroid if there's evidence of inflammation, or sometimes we stop. So the other steroids are not as well studied. For example, methylprednisolone, which is an intravenous steroid mostly. But we use it in morbidly obese patients because you can titrate it to weight. So that can be substituted sometimes in severe and critical COVID. So steroids have a lot of evidence that they are life-saving and are the standard of care for severe COVID to critical COVID infection. But they are not recommended for mild to moderate COVID. And the reason being, we feel that they may impair the body's immune response to the COVID. So in response to COVID, your body forms antibodies, and that may be protective. So if you give it too early, then this may impair the response to COVID, and your condition may become paradoxically more severe. So I would caution against early use in asymptomatic people and in mildly to moderately symptomatic people who are not on oxygen. I hope that
Yes.
clarifies.
So that's very good advice, because steroids are immunosuppressants. So if you take it really early in the illness, like you said, instead of helping you, it might even harm you. And so you have to take it at the appropriate stage of the illness, which is when the cytokine storm sets in and there are infiltrates in the lung. But also steroids have got their own side effects and complications. And a lot of our community patients, unfortunately, because of stresses and lifestyle factors, are suffering from diabetes, both type 1 and type 2. And steroids, they do alter the blood sugar. So what is not common knowledge perhaps is that when people take steroids, you have to closely monitor the blood sugar levels and other parameters. Do you want to talk a bit about that on the people with comorbidities, and how the use of steroids needs extra precaution?
Yes, steroids are a big problem. People with comorbidities, especially type 2 diabetes or type 1 diabetes, and generally hyperglycemia is a big concern. If they're hospitalized, of course, the hyperglycemia can be managed, at least in the United States, by titrating to increasing level of insulin. So in India, if, for example, the patient is at home and they're hypoxic and they're on steroids, then the diabetes medications may need to be adjusted or increased to cope with the rise in the sugars, because that itself can lead to complications. And hyperglycemia can itself be a cause of hospitalization. So careful monitoring of the blood sugars is very essential. on steroid therapy. The other side effects of steroids, like suppression of the adrenocortical axis or peptic ulcer disease, rise of infections, are related to long-term use. For example, COVID patients have been on steroids for quite some time, for example, in the hospital, then those complications can happen, including even some infections like fungal infections, which you've seen here. But in the short term, they're not as important as I think the control of sugar, I think, would be the most important concomitant complications.
Yes, no, thank you for that. So now going down the list of drugs with evidence, we come to the second most commonly used medication is remdesivir. And
Correct.
remdesivir has got quite a bit of evidence, and more evidence is coming. And more recently, we've had the adaptive COVID-19 ACTT trial, and that has come very strongly in favor of using remdesivir, but again at an appropriate stage of the illness. So Dr. Jogi, do you want to take us through when remdesivir should be used, under what conditions, because it's a closely regulated drug, and what is the latest evidence for its use?
So, like you said, that remdesivir is some sort of a frontline drug in the use of COVID infections. And for that, you have to understand the mechanism of COVID infection. At first, the signs and symptoms of COVID infection are from the replication of the virus. And later on, the body's immune system responds to the virus, and the excessive response of the body's immune system to the COVID is what is responsible for late complications and critical illness in COVID. So the virus is known to replicate for approximately 1 week to 10 days. So this is the time when remdesivir is effective. So there is enough evidence to suggest that if used in the first week of, I'd say, severe illness, but not critical illness, then remdesivir reduces the duration of symptoms from 15 to 10 days. So several days of symptoms are reduced and patient can be discharged early from the hospital. But remdesivir does not affect mortality, so it's not a life-saving drug. And that's why the WHO does not recommend it for poor countries in their guidelines. But if it's available, then it should be used in the first 7 days of severe cases, severe hospitalized cases. From the duration is between 5 to 10 days. That may lead to a reduction in the duration of symptoms and early discharge from the hospital. But if the patient is critically ill and is on the ventilator, there's very little evidence that remdesivir will work. In either case, remdesivir is not a life-saving drug. It does not reduce mortality, just symptoms. So it's like taking a relief of symptoms, essentially. So I think some of the excessive hoarding or seeking of remdesivir in the Indian context is somewhat illogical. So I would say,
Yes. So that's the worry, and obviously it has to be used under specific conditions. So Nijaji, you had a question.
Yeah, not a question. I just wanted to say this, that I have heard a lot of people have been kind of on this medication, remdesivir, right away, the moment they get tested, without consultation and without checking with their doctors. And they feel that, okay, it's going to, reduce their, chances of getting a moderate or severe condition. So I would want you to, as a doctor, as an expert, to reiterate that that's not, probably that's what I heard, that that's not, should not happen, not on your own.
correct.
And sure.
Correct. There's no evidence that remdesivir prevents the progression of COVID from asymptomatic, mild to moderate to severe cases. So its use in this context is inappropriate. And remember that remdesivir is a toxic drug. It does lead to liver failure. So one has to be mindful of the risk-benefit ratio. So not only using it in early stages would be wasting it, but also putting the patient at risk of complications unnecessarily. The risk-benefit ratio is only in favor of the drug when the patient is a severe illness and is hospitalized. And that too under close monitoring with liver function tests, kidney function tests. Kidney function is also important because it has a toxic metabolite called cyclodextrin, which accumulates in renal failure patients. So you have to measure the kidney function. So it's a hospital drug. You have to be closely monitored for it. Of course, if the hospital bed is not available and you're hypoxic, you have severe COVID at home, then if you can I get it, but again, the labs have to be monitored. But again, I would caution that this is not a life-saving drug. So ultimately, the mortality is not going to be affected. So, so that would be the context.
Yes. So I think the evidence from ACTT trial is that it reduces hospitalization 15 to 10 days. That's all it does. It's not a life-saving drug, as you said. So no, thank you for that, and thank you, Nijaji. So we will be taking some questions from the audience, but moving down the treatments which are being used. Now the third most commonly used one, and the one which is causing a lot of anxiety and lot of distress is the plasma. So every day you see a lot of messages coming for plasma exchange, and thankfully in India there's a lot of donors who have volunteered, people who have recovered from COVID. They are volunteering, and there's a lot of community volunteer groups. We are very thankful to them. They have a database of people who are donors. So again, a plasma exchange has to be done in a very regulated way. And what do you think what are the criteria that are being used in US before plasma exchange is? I have to say here that in UK where I work, there is plasma exchange is not used at all, except in trials. When if you are a part of a trial. So yeah. So what is your experience from US?
So it's a very mixed experience. So initially, when COVID started, we started using plasma quite liberally. And there were a lot of donors, and we had a lot of hospitalized critically ill patients. But in many cases, we noted no benefit, and in some cases, we noted a higher mortality and worsening. And I actually had 4 patients who became worse, and 2 of them eventually died after plasma. So the evidence for plasma is very equivocal, it's very uncertain. And the evidence of this, so I'm actually looking at the evidence, and there are 10 trials. And there was one trial which showed positive benefit, and you had to be given within 72 hours of the onset of symptoms, which is basically non-hospitalized patient where plasma is not available. So for hospitalized critically ill patients, the benefits of plasma are uncertain. And the Infectious Disease Society of America recommends its use only in the context of a clinical trial. Personally, I have used plasma. I have found no miraculous benefits, and I've had worsening and deaths from plasma, which is a known thing because it's unclear if what the reason was, but the possible mechanisms which have been studied are that it worsens the immune response um, from the antibodies, and it also a reaction and pulmonary edema from a reaction to the plasma. But so it should be used with very caution under very controlled circumstances, and it's also not a life-saving drug, unfortunately.
Yes, absolutely. So, but it is being used. It is being used quite a lot in India. So, if we could go through that, okay, if you are planning to use a plasma, or if the patient is due for plasma, what are the criteria? For instance, related to age and other comorbidities. Are there any specific criteria which people need to follow before they can be eligible for plasma exchange?
Well, convalescent plasma, first of all, it has to be high titer. This data suggests that low titer plasma, which is low titer antibodies, do not work. And I don't know if they measure titers in India. In the US, the low titer plasma is no longer being used. So only high titer convalescent plasma is being used. Well, I guess so the patient has to be obviously severely ill for the risk benefit to have some favor, some tilt in favor of plasma. But again, I would say that from the US standpoint, we've almost stopped using it. We used to use it in severely ill patients before they got intubated, before they got ventilated. For example, if they were on high amounts of oxygen. So obviously comorbidities would be that, if you have congestive heart failure, any other condition in which you can go into fluid overload, plasma can trip you over into that. Then if you have a reaction, so it has to be, you can have a transfusion reaction, it's a blood transfusion. So it has to be typed and cross-matched. So I would say, I'm not a proponent of plasma, and the evidence is kind of against it mostly.
Yes.
So disappointing a lot of people because there are donors and volunteers, but
Yes.
there's no strong evidence that it actually works.
Yes.
Some data suggests it prevents progression from severe to critical COVID, but it's very weak. And maybe the time to use it is when you're on a high amount of oxygen and you want to prevent them from getting on the ventilator. But then again, we're not sure of its efficacy. And the trials are all available on the NIH website and the Infectious Disease Society of America websites, and you can look at the evidence yourself. It's fairly equivocal and very weak. And
Yes. I mean,
personally, I've
I
used
would.
it in hundreds of patients, and I haven't found benefit. So
Yes. So I would agree with you because in UK we have the NICE guidelines and they look at all the evidence, and again, like you said, the evidence is very equivocal, and but it is being used. And thank you for letting us know the criteria for that. And we have to be careful if you are already having congestive cardiac failure. It is like blood. If you have blood transfusion, you need to be wary of congestive cardiac failure. You don't want to exchange one problem with another problem. So that is the issue. And I think by titers, you meant the antibody titers. So if people are going to be donors in India, they are doing the antibody titers, I know. And
no,
so it
what I
has
mean,
to be.
the antibody titers in the plasma itself, this plasma sample, which is collected from pooled donors, it has to have
Yes.
high titers.
Yes,
So
absolutely. So they are being done. I know that in India, the antibody titers from the plasma, it has to be high. I don't know which levels are being used, but it has to be high above a certain level. Only then it's going to be effective.
okay.
And so yeah, so that is that. And
I'd
so
like to
the
sorry, may I just interrupt?
yeah, of
I just wanted to
course.
summarize the Infectious Disease Society America guideline. Among patients hospitalized with COVID-19, the guideline recommends against convalescent plasma. So among ambulatory patients with mild to moderate, the guideline recommends only in the context of a clinical trial. So essentially, it's not recommended in the US.
Yes. So thank you for reading out the trial. But as is the problem in pandemics, there is a lot of anxiety, and you can almost understand. When your loved ones, you want to throw everything. Whatever the cost, whether there's evidence or not. It is like just throw everything at that, and you just hope something works. But in times of when there is shortages, when the plasma is short, when remdesivir is short, then I think to know what the evidence base is behind all these medication kind of puts things into perspective, so that the efforts can be focused on things that are actually working and the things that actually have a lot of evidence behind them. So thank you, Dr. Jaggi. So Nirjaji, you had a follow-up question on that?
Not a follow-up. I think he pretty much answered whatever was in my mind. But I want to go to the next topic, which is very much important. That's the vaccinations. There's a lot of back and forth about whether to get vaccinated or not. But personally, I mean, I'm not a doctor, nor do I have any authority to say it. But I do believe that vaccination is a must for everyone. But you could probably enlighten our folks a little bit more about it. The efficacy, and even after getting 2 doses of vaccination, is there a possibility of getting COVID, which there is, I know, but how bad it's going to be, or how the vaccination is going to be a little bit of shield for anything getting worse. So, Dr. Saab, please.
So, I mean, there are different vaccines, and the vaccines available in India are different from the ones available in the United States. So in India, they have the Covishield, which is the AstraZeneca, and they have the Covaxin. And I believe that AstraZeneca has good efficacy. So there are different viruses. Now you know that the virus has mutated, and there are several strains. And nobody seems to know which strain is causing the infections in India currently. So that has to be found out, whether this is the double or triple mutant, which they were talking about. Because I think the wild type infection was in the previous outbreak until September, and I think this was a different strain. So I would say anecdotally from what I hear that in India, because I know all the physicians and the medical staff have been vaccinated, and those people who have been vaccinated in India are getting a mild illness. So it's protecting them somewhat. So the efficacy of AstraZeneca against the wild type virus, the original virus, was around 75, 76%, according to the last data. and that meant that 25% could still get the infection. And but efficacy against hospitalization and severe infection was much higher. They claim 99-100% efficacy. So that's the main aim of vaccination, is not to only prevent illness, but also to reduce the morbidity and mortality associated with it. And that's why the vaccines are important. And the vaccines are important to reduce the infection in society. For example, if the vast majority of Indians had been vaccinated, so their chances of getting COVID or spreading it, and the spread of COVID would have been greatly retarded. So, so there are multiple benefits of vaccination. It's not just the individual protection, but also spread within society. And eventually, this pandemic will only be controlled by vaccination.
Sure.
Personally, I'm a big, I recommend vaccines. I know the vaccines were all new and people were afraid of, but most of the adverse reaction which have been touted in the media, are 1 in a million, 2 in a million. So for example, they said AstraZeneca caused clots. It caused clots in 30 patients out of 17 million. And those 30 could not be attributed to AstraZeneca vaccine. They could have been just from natural causes, because this was the same as the incidence of clots naturally among the populations. So media is playing a very negative role in this, and they're hyping adverse reactions of vaccine, which are 1 in a million. So vaccines are mostly very safe, and they're effective in preventing infection and spreading it. So yeah, vaccination is the only way to survive and to move out of this pandemic, stop wearing masks eventually.
Sure. And there's a follow-up question on that. Once we get vaccinated, the normal thought is that, okay, now we are vaccinated, we can go and socialize, we can leave our masks home, we don't have to follow all the protocols. Would you please give a little bit of insight into that we still probably need to be disciplined?
Right. So the virus is still spreading. So that's the thing, that you could be still infected from someone and you could pass it on to someone. For example, if the vaccine protects you from hospitalization, you can still get the virus. You could infect your grandparents or people who are vulnerable, and therefore spread the virus in society. So we have to, again, it's the same thing, protect ourselves, protect society. So for example, children are not in the vaccination protocol yet, at least children under the age of 12. So they could get it, they could spread it to other people. So, and the virus is mutating. There are mutated strains of virus which cannot be covered efficiently by the vaccine. AstraZeneca has very little protection against the South African variant, just 25%. So suppose South African variant spreads in India, so the only protection from getting it would be the masks. So I would say until the pandemic is contained and the spread in society is limited, masks should be mandatory, and correct masking, wearing it over the mouth and the nose, and having a tight fit is very important. Unfortunately, it's an inconvenience, but there's no way around it.
Sure, thank you. Yeah.
Yes. So vaccines all the way. I mean, from experience in the West, where the vaccination drive, in UK, almost 50% of the population is vaccinated. And that has a very important role, because we were in the same position as India is a few months back. And fingers crossed, because of the vaccine, things are getting better. And like you say, it doesn't matter which vaccine you take. They've all got good efficacy. Although the trials have been hurried, whereas in the past, the trials would take 2 to 3 or even more years, they have been hurried, but it doesn't mean that they have cut any corners in it. And this is my personal experience of talking to scientists who have been involved in research of vaccines, is that everything has been hurried up because money has been thrown into it, but it doesn't mean that any corners have been cut or things like that have been done, which seems to be the worry for most people. So thank you for that, Dr. Jogi, for reiterating that very important advice. So going back to the treatments, the third most commonly used treatments are the Famiflu and the Tamiflu, all those things, which are also being used very early in the illness, and tocilizumab, which is a monoclonal antibody used against receptors. So again, being used, I think, very haphazardly at home because of the widespread panic. So would you want to comment on the use of Tamiflu and Fabiflu and
Well, I would say this: they don't work. Don't use them.
Right. Okay.
It's not very complicated. Don't use medicine just because you have it, because it will not work. So there are very few medicines which work against the virus or the disease caused by it, and Tamiflu is not one of them. Ivermectin is not one of them. Hydroxychloroquine is not one of them. The evidence is unequivocal in that, and you're only causing yourself harm. These medicines are toxic chemicals. So by giving yourself medicines which don't work, you're only harming yourself, because they're not innocent. They're not Ayurvedic or plant-based. They're toxic chemicals. You're putting toxic chemicals in your body and causing harm. So I recommend strongly against the use of any such thing, which is not proven by evidence.
So what about tocilizumab? What is your view on that? Because that does seem to have some evidence as compared to Tamiflu.
Right. So tocilizumab is a drug to be used only in severely ill patients who are progressing to critically ill. So there were many trials on tocilizumab. It's a very expensive monoclonal antibody against interleukin-6. Interleukin-6 is one of the main inflammatory mediators in COVID-19 infection, and its levels are very high. And the logic was that by curtailing it, you'll reduce the inflammation. And to a certain extent, that's correct. But there are like 10 or 15 trials. Each week there was a different recommendation. One week it was that use it, another one was don't use it. Eventually, the Infectious Disease Society of America, based on a trial called the REMAP trial, decided that it's worthwhile using it in some cases. And these are hospitalized patients who are severely ill, and they're progressing, they're getting worse, they're getting to critically ill. And in them, you should use 1 or 2 doses of this drug. Now, this drug is very expensive, it's hard to find, and it should not be used outside the hospital. And I've used it in many cases, and it reduces, so in severely and critically ill patients, what I saw was it reduces inflammation. You can tell the markers go down, but then they go up again. So the benefit seems to be transient. But it's in the guideline that you can use it in a certain subset of patients, but none other. So if you use it in a patient who's on the ventilator, it does nothing. So if you already, also you have to use it in the first 1 or 2 days so it's a very tight kind of a recommendation. So it should only be used by physicians under very kind of in a supervised setting. It's a very tight guidance of using it. Because of rheumatoid arthritis, it is available, but that doesn't mean it should be used in everybody. It doesn't work in everybody. So
yes, thank you. Nirja, you wanted to say something?
No,
you're on mute. Yes.
Oh, sorry. Yeah, there are a few questions. I'll just go through some quickly. Can vaccine jab be given to small children, and how, in what age group should avoid, what age group should be included? So maybe you could.
No, they can't be used in small children yet. We haven't studied them in small children. They can only be used in children of 12 and above.
Yes.
12 and above. Okay.
Yeah, I mean, here it's 18 and above, but anyway, yeah, 12 and above seems like fairly good.
Great. There's another question, which is kind of, I'll just read it to you. I have been a mild COVID positive person. I have seen that lying in sunshine affects the symptoms very positively.
I think lying depends on the Delhi heat. We could get heat stroke from lying in sunshine. But yeah, if you're in Kashmir, yeah, probably the sunshine will be beneficial. So yes. It depends. And sunlight is good. Sunlight does kill viruses because of UV light, but there's no evidence that it'll make your COVID better. But yes. In general, you get vitamin D, and there are positive benefits of it. And yes. Staying indoors is not really.
Yes, I mean, as a psychiatrist like Ned, it is an antidepressant. So probably it affects your mood, and you feel better in yourself lying in the sun, and that is in itself a good thing. So so now we come to the most commonly used treatment, which doesn't need any evidence, and that's the use of oxygen. So there is a question from a gentleman about SpO2 being 90%, and is there anything he need to worry about? He's 68, and the CT scan, I think the HRCT, it's 2 out of 25. So the gentleman is asking, does he need to worry? His SpO2 is 90%. So I think that needs a discussion in itself, because there is a lot of misinformation about at what stage oxygen therapy is beneficial. So should we talk a bit about the use of oxygen in COVID?
Right. So there's been these CT scores being propagated in India. I have no idea what they are, and I have no idea what they mean. So, I mean, if you have infiltrates in both the lungs, and your pulse oximeter, your oxygen level goes down below 90 when you're walking, then you need oxygen, because below that your organs get deprived of oxygen. About that, it's questionable. I know people feel better when they get oxygen. It's like it does have some of those kind of benefits, but whether it clinically benefits you, you probably don't need it. If your pulse oximeter, if on room air your pulse oximetry shows 90 and above, and remember one thing: the pulse oximeter is not an accurate instrument. In people with darker skin, it is less accurate. So if you're functioning, if you don't have, I don't know what CT score of 2 out of 25 means. I have no idea. But if you, seems like it might mean you have no pneumonia. So if you have no pneumonia, it could be an inaccurate. There's no reason for you to have a low pulse ox, your oxygen level, unless you have COPD or any other underlying lung disorder. So I would question the reading of the pulse ox. You might want to try other pulse oxes, try the contrary finger, try the nose or the ear. But yeah,
Yes.
if there's pneumonia, there's a chance that your oxygen is going to be low. And then if it's below 90%, then you should be on oxygen.
Yes. So yeah, like yourself, I'm not too sure what the CT scores mean, but I think, well, from a layman's perspective, I think the higher the score out of 25 it is, the worse it looks, according, the infiltrates, how they have infiltrated the how badly the lung is affected. So the use of oximeter is a very important thing, because oximeters are very easily available in India and everywhere else. And now everybody is advised to keep an oximeter at home, but you still need to, it's fairly easy to use. There are some basic rules you need to follow, which you touched on. The fingertips are the best place, but if there is dark skin, that affects it. If there's females using a nail varnish, and if they use on top of that, that affects the pulse oximeter. Some people use it on their toes, which I don't think is a great idea at all. But earlobes seems to be the next best option, I think. So there is a lot of anxiety, because if because of COVID, even people who don't have COVID, like I have a pulse oximeter at home, and sometimes, just out of curiosity, I check my SPO. It's kind of become like
Yeah,
that. And if you do get COVID, you are obviously going to be very focused on the SPO, and then you realize that it's not that every day you'll have the same read. It's not something which is going to be the same every day of your life. Even in normal situations, while you're walking or sleeping or getting up, the values are going to fluctuate. Just because you are monitoring it more now, it is probably something you are more aware of. So that is important. But would you advise, for instance, charting it, and then you have a kind of an objective perspective of, like we do for hypertension, we are advised to take blood pressure at the same time of the day, then monitor and see if there's any major fluctuations. Would that be advisable for measuring SATs as well at home on oximeters, rather than doing it all the time?
Yeah, I would say that if you have COVID, probably you should be checking it multiple times a day. And yeah, I mean, charting could help, but this is more like an acute situation, unlike high blood pressure, so which you could deteriorate at any time. So that would be, more frequent kind of a thing. So yeah, if it's feasible, charting is always good. Yeah, I mean, but I would say the parallel is a little different here, because you need to check it very frequently. If you're feeling short of breath or something and you're positive for COVID, then you might want to monitor it like every half an hour or so, and that makes charting difficult, I would say.
Yes,
But,
it
but
is hard.
yeah, but yeah,
But
charting is always good. It's logical, honestly.
because sometimes it's best to have an objective kind of evidence, rather than just
Right,
rely on memory and then getting
right,
anxious. Like I said, being a psychiatrist, I do see a lot of people getting anxious and panicky.
right,
When we had COVID here, pulse, everybody was checking their stats, whether ill or not ill, and
right.
they just flew off the racks, and from Amazon was flooded with requests for pulse, which is a good thing, because it is very reassuring. And if you've got COVID and then your SATs are okay, it does reassure you, and
Sure,
then you
sure.
can monitor it and get help early. So
Yeah,
that is the big advantage of. But again, they're not 100% sensitive, which is kind of disadvantage. But much better to have them at home than not to
right,
have.
right,
That would be
right.
the
Yeah, I do strongly recommend that everybody keep one at home as in the correct context. Yes.
yes. Okay.
there's a question about CPAP. Can CPAP replace oxygen in urgency?
Probably not. CPAP is positive, and expiratory pressure. That's for sleep apnea. That's just air under
Right.
pressure. No, it can't
Right.
replace oxygen.
No, no, yes. And
So
this,
on that note, we are going to, we'll just let the audience know that we are going to have a separate session on the use of CPAP and BiPAPs because the thing with CPAP, a lot of people are saying that they have got them at home anyway because of sleep apnea. It's widely used the CPAP machine and the BiPAP at homes. So is there, while people are waiting to go into hospitals and trying to get oxygen, is there any benefit of using them as interim measures? So we are going to get some experts on that and possibly have some demonstrations on that, because I think that would be very useful for the audience at some point. But that's a very long discussion, and probably we'll have
I
to.
think for pulmonologists, yeah, I think that's a question for
Oh,
them.
that's a question for pulmon. We are going to get some very leading pulmonologists on our panel over the week, and I think that's the question we are going to
Yeah.
ask them. So, Nirjaji, are there any more questions from the audience?
I think pretty much we covered everything. There was one question about steam inhalation, or whether that is in some ways preventive. I mean,
Probably not, but if it makes you feel better, you can,
yeah,
but it's not
if it
preventive.
makes, I know, if it makes you feel happy about it, and it's
Yeah.
not harmful, so you can.
Yeah, I saw a
Uh,
picture in India of several people getting steam inhalation in some kind of booth, and that was.
But
yes,
I
you
I
did
thought there was
talk
a
about
COVID
that.
risk. They were at risk of giving COVID to each other.
Absolutely. So
But I
those,
did see one more thing on circulating on Twitter, WhatsApp groups, a pressure cooker being used as a steam inhalator, and I don't know
Right.
if that's even safe to even try.
Yeah, you don't want an explosion to kind of.
And yeah, it's
yeah.
not. It's not. Don't get
Uh,
yourself in trouble
Right.
unnecessarily. What has not happened has not happened. So
yes.
Right.
The
Right.
the thing, this is my personal view, I'm not an internal medicine specialist, but it might not help you with the COVID, but there's a lot of people who get a congestion in the nose, and so maybe it might benefit those people who, as because of COVID, they are finding that their nose and throat are being congested. So they, it might not help fight the COVID symptoms, but accessory symptoms of COVID. So I think in that context, people are using a lot of steam inhalation. Pressure
yeah,
cooker is obviously quite risky, but in steam inhalation devices, very freely available in India.
yeah.
Yes. So Nirjaji, any
That
more
was
questions?
that was going on in rounds, and I was really alarmed at seeing people recommending even that. That's not. Yeah, there is one more question here. For the jabs, do the jabs have a tendency to trigger systematic inflammation or clotting, which probably you discussed earlier? But some doctors in India advise blood thinners and as anti-inflammatory drugs. Is that okay?
No, the blood thinners are not recommended for outpatients. They're only recommended if you're hospitalized to prevent clots. COVID does have a tendency to give you clots if it's severe and you're hospitalized. And people do we use injectable blood thinners here to prevent that. But there's no data to support use of any blood thinners at home if you're not critically or severely ill.
Right.
So I would
Yes.
advise against it.
So so that's very good advice. But would you advise, as part of the blood tests, to get a D dimer done, and that might give an indication of what the clotting profile is like?
Well, I mean, D-dimer is used as a marker as a screening test for DVTs and pulmonary embolism, but you have to have some symptoms to justify it. We used to use it a lot in hospitalized patients with COVID initially, and then base the dose of the blood thinners if the D-dimer was elevated or not. But now we have found there's data which suggests that high doses of blood thinners cause bleeding and have no benefit. So we don't use it as much. I mean, unless we suspect a pulmonary embolism or a DVT. It's used as an initial screening panel, but not routinely everyday kind of a thing. So for outpatients, probably not. For inpatients, yeah, you could justify it.
Just, yeah.
Yeah,
And on the topic of blood tests, one of the key marker is the C-reactive protein, which a
right,
lot of people are getting done,
right,
at home. And there
right.
is a lot of anxiety around the CRP levels. And as you know, even if we routinely take CRP of a lot of patients, there'll be a lot of fluctuation from month to month and year to year, and it will be, and especially in COVID, obviously it's inflammatory. It starts an inflammatory reaction, then the CRP is going to be raised. So at what level do we really need to start worrying if we just focus on the CRP levels?
The CRP is just a marker of inflammation. So if you're sick, it'll be high. If you're not sick, it'll be low. So there's no reason to use it. If you're feeling okay, you don't need to measure your CRP. And it has no value because it's just a marker of the body's condition. If you have a lot of inflammation, you need to go to the hospital anyway. If you need oxygen, and so your CRP is going to be high. The only practical use, we've used CRP as to give tocilizumab. These days, if the CRP is over 75, we consider that a high marker of inflammation. And that's because interleukin 6 is more expensive and harder to do. So we just use a CRP as a substitute marker. But if you're at home and there's no need to do it. If the only thing you need to measure is pulse ox. And if you're feeling really sick, you have to go to the hospital. And if your oxygen is down, in the pulse ox, you need to get oxygen. So I would say that's all you need to do as an outpatient. There's no need to do CRP. There's no point. I know that people in India are using it even after they're sent home from the hospital. It has no intrinsic value. It just means there's inflammation in the body. But you can tell that yourself. If you're feeling sick, you probably have inflammation in your body. So it's like a common sense thing.
So I think one of the downsides of blood tests being very freely available, not at the moment, it's very difficult to get blood tests done. But normally in India, blood tests you can have them on demand, really. You can get them, you need a blood test. So I think one of the disadvantages is that over-reliance on blood tests as a marker of your general health. And I have heard of people using CRP as a marker. So once they come out of hospital, then do CRP, and then the next week do it again, and then see if the level, is it going high, is it going low? So it is kind of used as a reassurance, but it is not that. Your CRP might, it might not go down for a while. That's also a possibility. Yeah, Dr. Jogi?
I'm sorry, could you repeat that question, Aikana?
No, I'm saying CRP levels and even WBC counts and neutrophils, they are people are doing them multiple times. I think as a way of reassuring that things are getting better, as a psychological thing. And but what you're saying is that it's not the way to go, because blood tests can remain the same for days and weeks. And
the CRP typically we use the CRP commonly in other infections, for example, bone and joint infections. It takes at least 2 weeks to change significantly, so it's not an accurate marker if you do it day to day. It takes at least 2 weeks to change. But then again, the best marker of whether you're doing well is if you are doing well. If you're feeling better, that means you are better. That's why I tell my patients, if you feel sick, you're sick. If you don't feel sick, you're not sick. So it's like, there's no point in doing it as an outpatient, especially if you're recovering from the illness. And even before that, if you're not in the hospital, if you need oxygen, then you have to get oxygen, or you have to go to the hospital. If the CRP is elevated, that's not going to give you more information. For example, if you have COVID pneumonia, nothing will be different if the CRP is elevated. It is going to be elevated. So because there's no benefit to doing it, why do it? Why waste money and resources?
Yes, and maybe use the resources better to get things like your blood sugars and HB1AC and all those markers, which are going to make a good significant contribution to your general health and well-being. So instead of focusing on these markers, which are not very valid. No, thank you for that. And Nirjaji, did you have any questions?
There are more
from the audience
questions coming from audience, so I'm just kind of sipping through it. There's one question about what are the early red flags of a cytokine storm. How does one know?
So cytokine storm is basically the body releasing a lot of inflammatory mediators. Your white blood cell release certain chemicals like interleukin 6 and others. And that means high fevers, body aches, then joint pains. Then also you can have nausea, vomiting, and diarrhea as GI symptoms. Then obviously increasing shortness of breath, because the lungs are being flooded with fluid when you're going into the cytokine storm. So generally you feel very sick, and the symptoms involve multiple systems. But high fevers in COVID are a sign of a cytokine. combined with increasing shortness of breath and body aches, usually mean that you're going into the cytokine storm.
That's great. Thank you. I just want to tell all those who are watching us, if we miss out on any question, we'll definitely get back to you, answer that. As, one of our, specialists will address that question. So we're not going to miss anything out there. So yeah, Shafalika, you have something?
Yes, so that's important. So if any of the questions are missed, we have other doctors on the panel, Dr. Surinder Kaur, Dr. Rana as well, who have been answering questions on Facebook. So if anyone has a follow-up question, we will be answering on Facebook as well. So Dr. Jogi, thank you for your extremely valuable insights into the treatment and management of COVID based on your own experience in US. I mean, some of these, it's hard to replicate things in different parts of the world. So what's happening in maybe US or UK, it might not be possible to replicate the same management strategies in India. But the thing with medicine is there's always evidence based, and what things work and what things don't work, they are universal, because human beings are the same everywhere. So what is going to work in US is also going to work in India. And that is the point of having you today on the panel, was to share your insights on which drugs have the strongest evidence. And our job is to pass on the information, but and people, I'm sure they've learned quite a few valuable things today. So thank you for that. But before we finish today's webinar, do you have any experience on use of mechanical ventilation, and at what point do people go from being on maybe a CPAP and the BiPAP, or into intubation and tracheostomy and mechanical ventilation?
Okay.
So we could touch on that. We will obviously, like I said, we've got a pulmonologist coming soon in next couple of days. But if we could just start the discussion today.
Okay, so from initially when the COVID pandemic started, no, that's a very technical question for pulmonologists, but I'll answer it as best as I can. When the pandemic started, we thought that everyone had to be ventilated, so we used to intubate patients quite early. But we found with experience that that is quite detrimental, and now we have moved to avoiding ventilation and even avoiding BiPAP / CPAP, whatever else you call it. We go via high flow nasal cannulas. They're also called telefluxes. There are these plastic tubes through which you can give oxygen up to 50 to 60 liters. And most of our critically ill patients are on those, the majority of them. Only when we fail to oxygenate them on that do we go to BiPAP and ventilate them, if even BiPAP doesn't work. So ventilation is like a last resort phenomena, and we're avoiding it in most people because the mortality rate on the ventilator, even the United States, is quite high. It's up to 30 to 40%. In fact, my pulmonologist colleagues were saying it's up to 60 to 70%, even in the United States. So that means that your chances of dying on the ventilator are two out of three. So it's better to avoid to get to that point. I don't know if teleflexes, the high flow nasal cannulas, are available in India. I remember that physicians in Jordan, they made a big effort. They bought tens and thousands of them and shipped them over there to Jordan. And you can give very, very high, if oxygen is available, obviously that's another issue, then high rates of oxygen through that, and avoid being on the ventilator. And being on the ventilator is, it's almost like a death sentence, even in the United States. It's and the kind of ventilation on the ventilator, what technique they're using is called lung protective ventilation, and that the pulmonologist can tell you more about.
Yes, so we will have a separate webinar on mechanical ventilation, because like you said, it's a very anxiety provoking device to use for carers and patients. But fortunately, from the UK context, we've had some good experience with friends and all who have come out of mechanical ventilation and are doing very well after 6 weeks and 7 weeks, and most of them went to tertiary hospitals and obviously we are very, very grateful to the doctors there. So although the prognosis is not that great, even here, like you said, I think here it's 50% or something in tertiary hospitals where people can go on ECMO and all. That's another thing we will discuss with the pulmonologist, is the use of ECMO, which is being used here as well. And so, yeah, like I said, very fortunate to have had friends who recovered very well on mechanical ventilation. So we have to have hope, and we have to be positive, and miracles do happen as well. Medicine is not the be all and end all. Medicine and miracles and praying and everything else together, we'll throw everything at COVID and then see what comes out at the other end. So thank you, Dr. Jyogi, for your valuable time today. It has been great to have you. You have been on these webinars for the third time, I think, but today we had a rather detailed discussion on things. And I know you are a very busy person, and with COVID, things are very difficult across the world. So thank you for taking out the time. And thank you, Nirjaji. Do you want to finish today's
I'm here.
webinar? And
I'm
I would just
here.
like to add, I'm sorry, before I end, I'd
yes,
encourage all the physicians in India to go to these websites, the NIH COVID treatment guidelines and the Infectious Disease Society of IDSA COVID treatment guidelines, because they're free and they're on the internet and all the evidence is there. Even the WHO has guidelines. I would say follow that evidence, follow those guidelines instead of making up, opinion-based medicine stuff. So, and this is free, it's available. The knowledge is freely available on the internet. The NIH guidelines, it's on nih.gov /critical care /COVID. So they can find it, they can Google it, and all the evidence, all the papers are there in one place. So they can help that to guide them.
yes. I mean, obviously in India, doctors, they are following protocols and evidence-based. And I've got very good friends who are pulmonologists in India, and they are kind of high up on the evidence and this and that. But thank you for that, and we'll put that on Facebook. It's good to know of better ways to get evidence all in one place, because in these critical times when time is a very valuable resource, it's best to get everything in one place rather than having to look in 100 different channels. So we will put that on the website. So on that note, we would like to thank the audience for joining us. As Nirjaji said, if there are any more questions, please put them on the chat box and we will get physicians to reply for them. So thank you, Dr. Jogi, and namaskar.
Thank you very much. Thank you,
Thank
Namaskar,
you,
Nirjaji.
thank you, everybody, for watching. We are with you here. We are your support here. We'll be around to answer any of your questions. Please reach out to us. I'm here. I'm a facilitator. I'm not a medical person. I just convey questions from one corner to another. So least I can do from here. So namaskar. Stay safe.